Well, good morning. The opioid use disorder and the medical treatment, it's a big elephant. There are two parts of the elephant I was asked to sort of briefly allude to this morning. One is comorbid psychiatric disorders, and the other is the elderly. So let me start with a small anecdote. So most of you have probably heard Congressman Patrick Kennedy at some point talk about mental illness, a big national advocate for that. And one of the things he said that struck me, he said many things that struck me, but one thing in particular is that when he first started to publicly discuss his bipolar disorder and addictions, he was asked to sit on the board of several mental health advocacy groups. And one of them said to him early on that we have a focused mission. We advocate for specific serious mental disorders. And he asked, like what? And they said, so schizophrenia and bipolar disorder. And then they pointed out, at least as one individual pointed out to the congressman, we don't want to deal with things like addiction. So he said, he asked him, so you want to discriminate against people like me? The danger here is that we create our own internal hierarchy of what's more stigmatizing, less stigmatizing, real disorder, not real disorder, etc. I mean, none of you would do this, of course. But the presentations yesterday focused, and appropriately so, largely on one phenotype, which is the adult presenting primarily with opioid use disorder and its medical treatment. And that is an important phenotype, clearly. I would like to acknowledge that at the outset. But this is not all we say in the world of patients who cope, manage, etc., with addictions. We know now from an abundance of evidence, both from neuroscience in terms of sort of genetic risk factors, to the extent one can clearly speak about risk genes in this area, it's complicated, psychological risk factors including early life abuse, stresses, the neurotransmitters that are invoked, sort of dopamine, opioids. There's no serious mental illness, including addictions, where these are not all talked about, which is one big challenge in the clinical neuroscience and basic neuroscience area, a considerable overlap of neuronal circuitry, neurochemistry, etc. Given that background, it shouldn't be surprising to anyone that there's considerable comorbidity of psychiatric disorders in patients with opioid use disorders. Speaking of data, the data are fairly consistent, though there's a wide range. I guess we have elections in less than a week, but sort of if one to, it's like condensing all the polls and coming up with common figures, which is hard to do. Lifetime prevalence of a major mental disorder, meaning prior history, ranges somewhere between 40 to 70%, depending on who you read, depending on what population is surveyed. Inpatients, outpatient, clinical samples versus population samples. It's considerable. Major depression alone is estimated to be a lifetime prevalence of about 40%, and prevalence at the time you're seen in a clinic or in treatment or in research studies is about 15%. Anxiety disorders, simple phobias, social phobias, again about 10%. And PTSD, especially in veterans populations, very high among those who prescribed opioid medications. There are two other categories we need to remember, in addition to depression, anxiety, and PTSD. One is other substance abuse, alcohol, stimulants, nicotine, you name it. It's present. Again, the numbers vary, but this is a very complicated patient population. And the third group, sort of the one individuals diagnosed with a personality disorder, antisocial personality disorder, and borderline personality disorder is very commonly reported. These are the data. This is the clinical picture that clinicians who see patients with opioid disorder encounter. It will differ depending on the setting, if you're an OB clinic, a psychiatry clinic, or a community-based clinic, but the data consistently show that these are the approximate numbers, and these are the common disorders you see. So does it matter? I mean, I would posit that ignoring other psychopathology, if you will, in an addictions clinic is as bad as ignoring addictions in a bipolar clinic or a clinic that takes care of psychotic patients. They cluster, they complicate the clinical presentation, and they interfere with treatment and prognosis. Consequently, I think it behooves all of us to take all of this equally seriously And the perfect would be a thorough a mental status examination for all disorders. It's easier to live in a silo. I get that, you get that. But that does no service to the patients and the communities that we are trying to serve. In terms of impact, if you walk into a clinic or a research study and you have a psychiatric disorder and or other substance abuse other than opioid use disorder, it adversely affects outcomes. I'm stating the obvious, but the data support that. To different degrees. What about treatment? What about concurrent treatment? The evidence here is weaker than I'd expect it to be. But there is some evidence, especially in the case of major depression, that concurrently treating this disorder could improve outcomes, not merely addiction outcomes, which is an important goal, but psychosocial integration and functional outcomes, which is really what we want our patients to do. The term recovery suggests functional recovery, social recovery, domestic family recovery, etc. I see a light flashing. So let me go on to the second part of what I was going to talk about, which is the elderly. The elderly, technically those above 65, though, it's a evolving definition. That's a group that received very little attention yesterday. It's a group that is a rapidly growing segment of opioid use group. About people above 65 and older, they use about 25% of the prescription opioid drugs today. Just that group. It is estimated that a third of Medicare Part D recipients, which is about 15 million in total, a third of them get at least one opioid prescription. And in Alabama and Mississippi, now I don't mean to pick on Alabama and Mississippi, but these are the data, it's about 45 and 46%. So roughly half of Part D Medicare recipients in both those states are on at least one opioid prescription. The complications are huge in terms of polypharmacy that the elderly receive, in terms of falls, respiratory depression, cognitive impairment, etc. It's a very vulnerable population that we talk about. Once you're diagnosed with opioid use disorder, the treatment remains the same, but it's a far more complicated treatment regimen with the elderly for a lot of reasons. I hope we can get into some of that during our discussions. Thank you.